So basically, this is going to be going over the major connectors. Major connectors are the ones that connect one side of the prosthesis to another. We just should know that it is usually rigid. It does not interact with the soft tissue. It does not interact with the tongue. This is specifically for the mandible. It does not interact with the gingiva, like the free gingival margin. If it is not covering the teeth, the major connector must be 6 millimeters from the maxillary gingival line, free gingival margin, and 3 to 4 millimeters from the mandibular free gingival margin. The borders must be parallel to the gingival margin of the remaining teeth, because it's just how it works, kind of like aesthetic in my opinion as well. Everything just follows. If it's a parallel, then it follows the anatomy. Then the other thing is that the gingival margin must be across at right angles. So this is to minimize the coverage of delicate marginal tissue. And basically, it's instead of like having like a bow going into it. And then what tissue requires the greatest amount of relief is a tissue that slopes towards the tongue. This is specifically for the mandible again. And let's go through the mandibular designs of the major connectors. The first one would be the lingual bar, and this is the one that's used most often because it's so comfortable. It has a narrow superior border. It does not contact with the teeth, except at the clasp basically, and it has to be 4 millimeters in length, basically 4 millimeters high, and 3 to 4 millimeters from the gingival crest, and then it has to be 1 to 2 millimeters from the mandibular floor, especially from the soft tissue. This is for it like not to interact with either the gingiva or the floor. Again, this is what we said, we're not trying to irritate any of these soft tissues. So it requires at least 8 millimeters of attached gingiva, and this is when like someone has like good periodontal health, stuff like that. It must be measured in the patient's mouth, because the stone casts do not usually outline how much like tissue we have. And it is, the only like downside is that it's not rigid, but basically you just have a little strap at the bottom. Then there's the second most used, which is the lingual plate, which is great for patients with tori usually, and the contacts are just above the cingulum, and the only downsides are that it traps foods, and there's some decalcification, and you have to make it thin because there's almost like an abrasion on the teeth from this. And this is for patients with less than 8 millimeters of attached gingiva. Then we use that. That's why we're like that's the only reason why we have it touching the teeth. Because if we have the 8 millimeters of attached gingiva, we would just use the lingual bar. Then we have like a mixed bar, which is like it's called double lingual bar, also labeled as Kennedy bar. Which has like one of the lingual bar at the bottom, and then one small bar that is contacting the teeth just above the cingulum, and we can call that a cingulum bar. And it is important that we label the rest there, because these rests are very, very like needed. So the higher bar is usually 2 to 3 millimeters in height and 1 millimeter thick. This is kind of thin, but because it is on the teeth, it has to be that thin, because it's going to be just awkward for the patient. And it should not be viewed from the frontal plane. So if you view this in the frontal plane, you should not be able to view this higher bar. It's specifically for aesthetic reasons, I believe. The lower bar is the same length as the lingual bar, which is the first one we talked about, and it's 4 millimeters in length. And usually we use it when there's like a lot of interproximal spaces, and basically there's like bad periodontal health here. And another thing that we can use is a modified lingual plate, which is like a similar version. Then we go to the labial bar, and it is mainly for people with large tori. This is so you basically like put it at the front of the lip. So bottom lip is like kind of like distorted a little bit, and facial surface bar, it has a large height, and we usually use it when the teeth are lingually positioned, or we have like large tori, And main thing is that it's bulky, so it's less likely to succeed because like the patients will even wear it because of how much like problems it gives them. And you might be just better off giving them like an orthodontic treatment, extracting the teeth or removing the tori. And it has low acceptance from the patients. Comfort at the lower lip is just bad, and it roaches on the gingival margins in most cases, because you have to remember patients with these problems usually are having like bad periodontal issues as well. And then we can modify either that or the lingual bar, and we can have a swing lock prosthesis, which has one hinge at one end and then a locking device at the other end. And we mainly use this when we're missing key abutments or we have bad tooth contours. For example, someone with like extremely facial inclination and stuff like that. This is when we use the swing lock, and it just makes most sense to do this modification at those points.